Both of these two processes, the neovascularization and the swelling, these respond very well to vascular endothelial growth factor inhibitors, which came in about 15 years ago and have been a massive advance in the treatment of macular disease. The other conditions we see are atrophy and scarring. These are conditions we still can't treat. So here you can see in this slide here, this macula of the left eye, you can see in the center there, the gray areas where the retina is still here. This side, the rest of it is all atrophic. There's big holes in the outer retina. And if you see on the cross section here, the base of the retina is all atrophic. There's no photoreceptors left here. So this region is blind here. So this is now becoming a major cause of blindness that we have not been able to treat. So VEGF inhibitors were the big breakthrough 15 years ago. This we have Lucentis, Eylea, and Avastin, and they've been extremely useful drugs for us. But the trouble is that they tend to not last very long. So a lot of people, maybe 20% of our patients, need to have 4 weekly injections of these things, some of them for the rest of their lives. We had a new VEGF inhibitor released recently called Beovu, which does last longer. It lasts 2 to 3 weeks longer. So a lot of 4 weekly patients get out to 8 weekly, but a lot of eyes got inflammation with Beovu, which has limited its use in most people. And as I said, we still have no treatments currently for atrophy or scarring. So there's 2 new developments coming along. The first is in wet macular degeneration, another new VEGF inhibitor. This is faricimab, which is likely to be released later this year. And I'm presenting slides from Roche. These slides for an investigational product. It's only just been approved in the United States. And then the second part of my talk, I'll be talking about pegcetacoplan, which may be the new drug for dry macular degeneration. So this new drug, faricimab, this is an antibody, as you see here, and the 2 top fragments are the variable fragments which you make against the target, and the heavy chain is the bottom piece here, which is the same for all antibodies. So they've modified the antibody now. So they've got 2, it's a bispecific antibody. The first antibody is against Ang2, which is something which stabilizes blood vessels. The second one is conventional VEGF blocker, and the heavy fragment here, the modified FC fragment, has been modified to reduce the drug getting into the bloodstream and reduces its potential of causing inflammation. So if we look at the breakup here, we're looking at dual inhibition now of Ang2 and VEGF-A, and we think this is going to lead to more stabilized blood vessels and a longer duration of effect. You can have a look here, diabetic with an eye with diabetic retinopathy on the left. This is what VEGF inhibitors can do. They can completely clear up most signs of diabetic retinopathy. So I know they're very good for retinal disease. At the moment, we use anti-VEGF all around the world to treat diabetic macular edema, same as we do for wet macular degeneration. But as I said, it doesn't last long enough, and it actually only gets at VEGF. It doesn't get to the other pathways which may be important in diabetic macular edema. And here's some results here. The numbers of patients who achieve various levels of vision in one of the big American randomized clinical trials, one of the phase 3 studies there. And they found that nearly a quarter or a third of the patients still didn't have driving vision, or only just getting to driving vision when they were getting, after they'd started treatment with the current drugs against diabetic macular edema. So this area of need is that the diseases we treat are not just VEGF driven. There are other inflammation and other aspects of these conditions which we're not treating with VEGF inhibitors. We want something that lasts longer. And also we know that in real world practice, because the drugs don't last for all that long, we don't get the great results that they get in the clinical trials. So this is what we hope that faricimab will help us with. Here's a study from America where they had a look at the number of anti-VEGF injections in the first year of people with wet macular degeneration. You can see if you only have 1, 2, or 3 injections, you don't get improvements in visual acuity. You only get the improvements in visual acuity if you get really, almost an injection every month for the first year. So you really need to be treating with drugs either that are stronger or last longer, and hopefully faricimab will answer this. This is another showing of the visual acuity improvements for macular degeneration. On the left, you've got the randomized trials where they had to be treated regularly, at least every month in some of the earlier studies, every 2 months for the later studies, whereas in real world practice on the right, people get many fewer injections and they don't do as well, don't get the visual acuity improvements. All saying we need to get something that lasts longer. So these are the big studies of faricimab. On top, you've got wet macular degeneration. On the bottom, you've got diabetic macular edema. And these are the visual acuity improvements. And they're looking at faricimab, the new drug, versus aflibercept, or the old drug, that's Eylea, over the first year of treatment. This is a visual acuity improvement. So the faricimab, which was given up to once every 4 months at the end of the first year, got the same visual acuity improvements as the current drug Eylea, which was given 8 weekly or twice as often. And then for diabetic macular edema, they also got good improvements in vision here compared to Eylea again, with less frequent treatment. The other thing we look at in clinical trials is the anatomic improvement, which is the reduction of the central swelling. And here we had swelling in the macula, which was reduced by about 150 microns in AMD. The faricimab had a slightly stronger effect, or at least as good as Eylea, for both macular degeneration and also for diabetic macular edema. And if you have a look at the dosing regimens, most of the patients, Q16 weeks means they got it every 16 weeks by the end of the first year. For AMD, macular degeneration, and diabetic macular edema, they could get out to 4 monthly treatments. Whereas, as I said before, for the regular drugs, most of them are still on 8 or 10 weekly treatments at the end of the first year. So this does get them out to longer treatment intervals. The other important thing about faricimab is we have not seen the big rise in intraocular inflammation that we saw with Beovu, which I said has limited its use, unfortunately. So we're not getting these nasty intraocular inflammation events in faricimab. If you have a look now at an eye that's being treated for diabetic macular edema, this is how we typically approach things in the clinic. You can see they're started on the left. We've got the thickness here, the central subfield thickness. The OCT is on the top there. And you can see at the start, it's quite swollen in the center here. This is diabetic macular edema. They started off with 4 weekly, then they were extended out to 8 weekly treatments. And after they got out to 8 weeks, the central part, which was what we're most interested in, was still not it was dry. So we extended further out to 12 weeks, and the central part remained dry at 12 weeks. So we're able to spend out quite quickly to 16 weekly treatments in this eye, and they've got a nice dry fovea and seeing quite well. In another case here, after 4 weekly treatments, they've got the central swelling there, which is receded from the center after the first 3 injections. They tried to extend it out to 8 weeks. That wasn't too bad, but then we extended out to 12 weeks. We're always trying to get the interval between injections longer. The swelling got back into the center again, so he would have had to drop back to 8 weeks at that point, do a couple more 8 weekly intervals, and then try to extend out to 12 weeks. And we got out there by the end of the first year of treatment out to 12 weekly, and the central part is still dry there, so that eye would be seeing well. So this is a status of the faricimab clinical development program. They've already finished the DME and the diabetic macular edema and the AMD, the wet macular degeneration phase 3 studies. So that's why it's being registered now in the United States and expected to be registered here probably in just a couple of months' time, and hopefully reimbursed by the end of a year. So this will be a real treatment option within the next 12 months for our patients in Australia. For AMD, the Balaton studies for retinal vein occlusion, and Cominos also for retinal vein occlusion. These studies we'll be completing halfway through 2023 and hope to see it for our patients with retinal vein occlusion later on. So the next part, the next development is the first drug now for geographic atrophy. This is so-called pegcetacoplan. And the big, this is important to realize that this is not for promotional purposes. This drug is not currently available. It hasn't been approved anywhere yet, but we're hoping that it will be maybe later this year or early next year. As we know, macular atrophy, as I said, is one now becoming a major cause of untreatable blindness. Probably about 5 million people have got this, and anti-VEGF, if anything, only makes it worse. So a lot of our patients with wet macular degeneration are developing this while they're on treatment. Now, the complement pathway has been identified as probably one of the major targets, or definitely is one of the major targets for atrophy, because macular degeneration is about 70 or 80% genetic, we estimate, about 20% environmental, 70 or 80% genetic, and most of the gene defects are in this thing called the complement pathway, which is a sort of innate immune system where the body monitors things locally, and it can turn on inflammation, and it can sort of remove cells and cause cell death and all these sorts of things. So these inhibitors all try to get at certain parts of the complement pathway. We've already had 3 or 4 of them, and they've failed the clinical trials, but pegcetacoplan is the first one that looks like it might pass the clinical trial. I'm about to show you that now. So this is where it works, and sorry. So they've done a study now, the Oaks and Derby, 2 major phase 3 clinical trials, and they gave it either every month by an injection into the eye, or every second month, or they got sham. So there was 3 groups. And here we can see the rate of enlargement of the areas of macular atrophy. So you had to have a certain size of macular atrophy when you started the study, and they monitored the growth of that. So here in the light gray here, you can see the patients in the Oaks study that didn't get any treatment, and then compared with the second monthly and the monthly, you can see that there was definitely a statistically significant slowing in the rate of growth of these areas of atrophy. So it doesn't make them go away, it just stops them getting bigger. So if you get atrophy outside the center of the macula and you stop it spreading into the center, then you can stop people going blind. And that's what these drugs are supposed to do. So the other study, however, in the Derby study, which was the other phase 3 study, there was a reduction, but it was not statistically significant. Statistically significant, it's got to be p less than 0.05. It's got to be, the chance event has got to be less than 1 in 20 in chance to regard it as being likely to be an effect of the drug. So it looks like a trend in the drug, but it wasn't statistically significant. Now, before they did these studies, they said, we will combine both big studies at the end of when they're completed, and take the overall result as the main result. And if you look at that, this is the combination of Derby and Oaks. There is a statistically significant reduction from every other month and from monthly treatment compared to the sham-treated eyes. So it does look as if this drug will slow the rate of expansion of atrophy. But it'll be quite different from wet macular degeneration, where you give someone a drug and their vision actually improves. There'll never be any improvement with these drugs for macular atrophy. All they will do is slow the growth, and the patient won't really be aware of it, and they'll need to have an injection at least every other month, like every 2 months, and some patients get the maximum effect, might need an injection every month indefinitely. They also looked at the patient's other eye that wasn't in the study, and they also found significantly lower rates of growth of the macular atrophy in the eyes that got the pegcetacoplan compared to the fellow study eyes. And this is an analysis showing the effect on the atrophy, which was not yet in the center. And that's the type you're going to go for to prevent it getting into the center. There's about a 25% reduction in the rate of growth of these lesions. So there were some adverse events. Some eyes got what we think looked a bit like wet macular degeneration. Maybe up to 10% of eyes got that. However, that did not adversely affect the outcomes because that was treatable with VEGF injections. So this is going through as we speak. They are putting up to the FDA at the moment, and we expect to find out in the next couple of months whether they approve it there. And I believe that they will be submitting in Australia later this year or early in 2023. So how does the Macular Research Group help all these efforts? Generally, the Macular Research Group reports, we report our research findings in our newsletter, which we release every year. Just Google Macular Research Group at Sydney University or Safe Sight Institute, and you'll find that. But where we fit in best with this sort of work, the new drugs, is the Fight Retinal Blindness project, because that tracks the outcomes of drugs as they're released onto the market. And we're probably the most advanced treatment outcomes registry in the world. We've already been able to show that BIVU does exactly what it does. They said it would do. It does last for about 50% longer than the present drugs. However, it's got these nasty adverse events, which, as I say, it limits its use. When Eylea came out, we were able to compare that with Lucentis, which was a drug at the time, and we didn't find a big difference between the two, actually. So we definitely feel that we will be able to show whether faricimab is lasting this extra month or two in eyes with macular degeneration and also with diabetic macular edema, and whether that's as big as an advance as we hope it will be. So that's the first half of the presentations today. I wonder if anyone would like to ask questions. But we do have some questions from the audience. In case, shall I start with that, Janet?
Yes.
I'll start with that. Okay, what are the costs involved with drugs or gene therapy? Generally, they say that a drug costs about $500 million to make it to the market. $500 million. So that's the preclinical development where you try to find targets in animal experiments and the sorts of things you do in laboratories. And then there's the phase 1 clinical trial, the phase 2 clinical trial. Then there's got to be 2 big international phase 3 clinical trials that we've just seen for the previous drugs. They both had 2 large phase 3 studies. So generally that costs about $500 million, which is why they're so expensive if they're successful, because they don't all make it to the market. Only about 40% of drugs which get to the phase 2 and they succeed in the phase 2, only about 40% of those drugs actually will get past a phase 3 and get registered and reimbursed. So that's why these drugs are so expensive when they first come to the market. Although the VEGF inhibitors are likely to come down in price now that Lucentis and Eylea are going off patent and they're going to get more competition there. There was another question here on MACTEL. Do we know what the cause of MACTEL, type 2 MACTEL, or macular telangiectasia type 2? We're getting we know. One thing to say about MACTEL is we know so much more about it than we did 15 years ago when we started this research program. We knew almost nothing about it. We thought it was a disease of the blood vessels. That's telangiectasia, refers to blood vessels which are dilated and squiggly like varicose veins. We thought it was a vascular disease. It turns out it's not a vascular disease at all. It turns out it's a disease of the cells which support the retina. They're called Muller cells, and they seem to be dying first, and then the photoreceptors die after that. And the other things we've covered, mainly from the gene analysis, is it seems to be a disease where serine synthesis in the retina is defective, because all the genetic hits, nearly all the genetic hits are to do with the serine biosynthesis pathway. So we're doing a lot of research looking at how the serine biosynthesis pathway is altered in MACTEL and how we can fix that. But we do have a phase 3 trial too of a drug, a serine neurotrophic factor insert, which also apparently releases serine. So the big news with MACTEL is that phase 3 study for that, we've got 2 phase 3s of that currently underway, and they should be returning the results later this year. The next question I can hand over to Matt. Matt, I wonder if you could tell us, is it still possible that gene therapy can help children with Batten's disease, JNCL?
Batten disease is a multi-system disease. So my understanding is that there are current gene therapies in development for Batten disease, possibly for that form of Batten disease, but you'd need to look it up on clinicaltrials.gov, the website run by the regulators in the US.
Another question, were there any questions on this chat? There's a big chat room here. There's a whole lot of questions here. There we are. Bottom where I can't see the questions. So here's another, I've got another question from previously. The role of epigenetics in macular disease. There's growing evidence that genes are not our destiny in chronic diseases. Is this also the case for eye disease? Well, Matt might like to say something about that, but epigenetics basically refers to the modification of our existing genes by various chemical processes, histone acetylation, these sorts of things, which can affect the expression of the gene. So it can turn genes on or turn them off. I think there's been a certain amount of work done on the epigenetics of the macular antioxidant system, because there's a lot of oxidative stress in the macula, and that appears to be vulnerable to epigenetic modification. But actually, it's quite early, it's still in its infancy at the moment. It's not something that we're doing a lot of. Do you know much more about epigenetics and macular degeneration, Matt?
Not really anything more to add. I agree that it's in its infancy. It appears to be possibly important and can possibly account for some of the variations in phenotype, that is the manifestation of disease in different patients. So for example, identical twins may develop very, very different macular changes. And one of the reasons to account for this is possibly epigenetic differences.
All right. Why is most research focusing on the advanced dry AMD manifesting in geographic atrophy and nothing's targeting early stage, such as trying to reduce drusen? Isn't prevention better than the cure? Well, yes, definitely. If you can get in early, then that would be ideal. The trouble is that people with drusen have got normal vision, so they're not all that keen to have anything done with them. So we know that with the trouble with atrophy is you can see that the atrophy is coming. There are certain, even before it affects people's vision, you can see that it's coming. And that might be the time, for example, to do a transplant of the RPE, the retinal pigment epithelium, which is defective. And if you could put a healthy RPE in there, presumably they wouldn't progress to getting the atrophy. But the problem is, who's going to want an operation if they've got normal vision, have a retinal procedure, which may or may not succeed, especially in the experimental stages when you're trying to implement this treatment. The other thing about debris is drusen is, yes, you can make them go away, but when they go away, they tend to leave the atrophy behind. So if you just hasten the life cycle, you just accelerate the degeneration. So yes, we do know of ways to make the debris go away. Laser treatment can clear the debris, but it can lead to progressive atrophy and the acceleration of the degeneration. So certainly people are looking at that, but yes, it's a difficult place to start. The people who are most likely to go to accept the interventions, the people who've got the disease. Darby and Oaks patient take ARED supplements. It depends where they are. If they were in the UK, they wouldn't have, because in the UK, no one recommends the supplements. The supplements are controversial. Most people who believe in the supplements believe that it will prevent, it reduces the risk of bleeding, but doesn't have any effect on the atrophy. So all these patients in Darby and Oaks would have had atrophy. It's unlikely that the supplements would have been very helpful in those patients. There's another question. Could you please explain how the inflammation side effect manifests, how long it lasts? Is it permanent? Didn't quite get that context of that question.
Possibly with Beovu.
Yes. Yes, there's a lot known about that. It only occurs in a very small proportion of patients. The serious one that causes like the loss of vision, which is irreversible, occurs in about 0.5 to 1% of patients. And it's an occlusion of the worst thing that can happen is an occlusion of one of the retinal blood vessels, one of the retinal arteries. And if you get that, then that's irreversible, unfortunately. It's close to rare. Most patients do very well on that drug, but there is this nasty adverse event. It usually occurs in the first few injections. And if that one occurs, it's not reversible. Most of the other causes of intraocular inflammation are reversible. You just don't give another injection of Beovu and they will settle with aggressive steroid treatment. So look, I'll hand over to Matt now, and perhaps there can be some more questions when he's done with his presentation.
Thanks, Mark. Can you see my screen okay?
I can.
Yep, fantastic. Thanks for the introduction. I lead my own group, but I work very closely with Mark. The group's called the Retinal Disease and Rescue Group. I'm an associate professor at SafeSight Institute, and I'm a vitreoretinal surgeon at the Eye Hospital. I'll be talking about gene therapy for macular degeneration. So by way of overview, I'll be running firstly through the broad principles of gene therapy as an approach. I'll cover how this approach is being used to address macular degeneration. And in doing so, I'll discuss clinical trials that are using gene therapy. These are all, it's fair to say, primarily they're early stages. Some are through to phase 3. Finally, I'll discuss some emerging approaches, and I'll touch very briefly upon some of the work my group is conducting. So in its broadest sense, gene therapy can be considered to be the delivery of DNA to treat disease. And as you all know, DNA is the basic language of our genetic code, if you will. It's difficult getting DNA into cells by itself. And for this reason, we need to use vectors to act as a sort of transport mechanism to get DNA into cells. The most commonly used vectors to date have been viruses, and of these, the most common virus to be used for ocular gene therapy is called adeno-associated virus, or AAV, which I'll cover in the next slide. Once we get DNA into cells, it's read pretty much like a recipe by the cell's machinery to produce a protein, and this protein has the function of modifying diseases. It should be noted that other techniques are on the near horizon, such as CRISPR-Cas9, which is in fact capable of editing the human genome. I won't cover this. As I said, the most popular means of getting genes into cells, at least for ocular gene therapy, is AAV, or adeno-associated virus. And in its wild type, or its naturally occurring form, it doesn't cause any known human disease. And for the purposes of gene therapy, it's made even safer by inactivating it such that it doesn't incorporate itself into the human genome. It's popular because we know that it works well. And in particular, it works well in tissues that has cells which don't divide and which are mature. And the retina is a good example of a cell with a tissue, I should say, with such cells. We also know that it will induce protein expression for long periods of time, so the effects should be sustained. There's a limit, however, to the carrying capacity of AAVs. And so whilst it's possible to carry most of the genes of interest, or many of the genes of interest in terms of retinal disease and retinal degeneration with AAVs, it's not possible to carry all of them. So I've given here the example of ABCA4, which is too large to fit into an AAV. And this gene is associated with a early onset form of macular degeneration called Stargardt disease. It's often said that the eye is a good target for gene therapies, and this is for a few reasons. First of all, it's easy to access because it's a surface organ. It's relatively small in size, and it means that only small treatment doses are required. And so these are easy to produce because we only need low volumes to treat. It also limits the potential for effects on the rest of the body. The eye also has what has been termed immune privilege, in that it's partially shut off from the rest of the immune system. And this potentially limits inflammation, although we'll see this can still be an issue, especially with intravitreal gene therapy. A further advantage of the eye is that we have ways of studying the living human retina in great detail. We saw some OCTs that were presented previously by Mark. And this makes it possible for us to monitor the structural response to treatment pretty easily in the clinic. Finally, if we're in the early phases of clinical trials, we have an inbuilt control if we treat only one eye. That is, we can track the natural history of the disease in the untreated eye and at the same time monitor the effects of treatment in the treated eye. So how do we deliver gene therapy to the retina? Just like other medications for the eye, gene therapy may be delivered via a few different approaches. First of all, it can be delivered in the office via an injection through the white of the eye, the sclera, into the vitreous cavity in much the same way that injections are given for wet macular degeneration at present. And this is a pretty straightforward procedure that all ophthalmologists are comfortable performing. It may be associated, however, at present with significant intraocular inflammation with some gene therapies. Secondly, injections may be performed underneath the retina. This is called a subretinal injection following a micro keyhole operation called a vitrectomy. I've got a video of this approach, which you can see in the bottom right-hand corner. And this is a video of me performing an approved gene therapy for a form of inherited retinal degeneration. This approved therapy is called Luxturna. And you can see me here injecting underneath the retina, raising a subretinal bleb. This approach is less prone to causing inflammation, but it's only performed by a subset of eye surgeons and retinal specialists. Finally, it's also possible to deliver gene therapy into the space underneath the white of the eye or the sclera, and this is called a suprachoroidal injection. This is more or less a halfway house between intravitreal and subretinal injection. It's still relatively in its infancy as an approach, but we may be seeing more of it in the future. So I'm going to cover a few different broad approaches to gene therapy for macular degeneration, and I'll start off by describing gene therapy approaches to treat wet macular degeneration by shutting down blood vessel activity. Next, I'll talk about ways of combating dry AMD using gene therapy. And finally, I'll talk about some newer approaches to restoring light sensitivity in degenerate retina, which may be appropriate for those with advanced sight loss. Mark mentioned that one of the big issues with current therapies for wet macular degeneration is treatment burden. That is, there's a need for ongoing injections of anti-vascular endothelial growth factor agents. And it's true to say that there are a variety of approaches which are being explored in parallel to deal with this issue, and gene therapy is one of them. The approach here is to introduce a gene via gene therapy which contains the genetic code for a protein that acts as an anti-vascular endothelial growth factor agent. Essentially, the eye will act as its own little mini factory for the drug. So most medications that are in development don't have particularly catchy names, and this is true of ADVM022. This is an intravitreal gene therapy in which the vector is one of the newer adeno-associated viruses. This is called 7M8. This gene therapy is designed to produce a protein that is very similar to the anti-VEGF medication aflibercept, which is marketed under the name Eylea and which has been approved in multiple jurisdictions for use in wet macular degeneration, as well as diabetic macular edema and retinal vein occlusions. There's been one trial reported using ADVM-022 for wet macular degeneration, which is ongoing, and it's called the OPTIC trial. This included 30 patients. All of the patients who were enrolled had what they termed as a high treatment burden, that is a mean of 8.5 injections per year in the year prior to enrollment. Patients could receive either high or low dose gene therapy intravitreally. So far, it appears that the gene therapy results in reduced treatment burdens. So, for example, only one patient in the high dose group required an additional intravitreal injection of Eylea in the first year following gene therapy. On average, visual acuity appears to be maintained in these patients, in fact, up to 2 years following treatment. In some patients, they've collected fluid, aqueous humor from the anterior chamber of the eye, and this is the space between the coloured iris and the clear window, the cornea of the eye. And analysis of this fluid has proven that in general, the eye produces therapeutic levels following this gene therapy of the target protein. The main issue to date in terms of side effects has been with inflammation, and this has been successfully treated to date with steroid eye drops. It's important to note, as I've noted at the bottom here, that patients on a different trial using the same medication for diabetic macular edema developed the serious ocular complication of sustained low eye pressure with loss of vision. This is called hypotony, and this caused this particular trial, the Infinity trial, to be halted. So moving on to RGX-314, which is another gene therapy for wet macular degeneration that has a catchy name. It uses a AAV again to deliver the code for a protein that in this case is very similar to ranibizumab or Lucentis, which again has been approved in multiple jurisdictions for wet macular degeneration. Although 2 delivery approaches can be used and are being studied in the future, subretinal and suprachoroidal trials in wet macular degeneration have largely focused to date on subretinal delivery. Patients included in their early phase 1/2 trial required frequent injections prior to enrollment, on average just over 7 per year in the year prior to enrollment. And this is a dose escalation trial which included 42 patients who received one of 3 treatment doses, either a low, medium or high treatment dose. So far, the treatment appears to be effective, reducing the treatment burden in terms of number of injections by around 2/3 in the first year following treatment. So, for example, on average, prior to treatment, the patients required just over 7 injections a year, and this was reduced to 2 in the year following treatment. So they still required, on average, some intervention in the form of a rescue injection of anti-VEGF. Visual acuity on average appears to be maintained following this gene therapy. And in general, the therapy appears to be pretty well tolerated. This is a subretinal injection and no reports of drug-related inflammation have been presented to date. Around 2/3 of patients develop pigmentary changes at the site where the gene therapy is delivered, the site of that subretinal bleb, which we saw in the previous surgical video. And this has been reported for other gene therapies such as Luxturna, and the functional implications of these changes are yet to be elucidated. The pivotal trial is called the Atmosphere trial, and it's of subretinal gene therapy, and it aims to recruit 300 patients. At the same time, a phase 2 trial using suprachoroidal delivery is planned. So next I'll talk about dry AMD, and helpfully Mark has already broached much of this. So the pathways to vision loss in dry AMD are complex, and one of the possible pathways to target is the complement pathway. As he said, there's evidence from multiple lines to suggest that some of the pathological changes seen in dry AMD are a result of dysregulation of this pathway. And so as a result, the complement system has become the target for new therapies, as we heard earlier. GT005 was developed by Gyroscope Therapeutics in the UK. It uses an adeno-associated viral vector to deliver the normal complement factor I gene, and this is via a subretinal injection. Complement factor I plays an important role in inhibiting one of the components of the complement pathway, which leads to inflammation and cell death. It's hoped that by boosting the levels of complement factor I following gene therapy, that we may halt the progression of dry macular degeneration. Phase 1 and 2 trials are underway or have been completed. Safe Site Institute and Sydney Eye Hospital will likely be a phase 2 study site from late June of this year. We're just waiting for site activation. So far, we've got limited data on its effects. However, it does appear to be safe and not associated with significant intraocular inflammation. I'm mentioning another dry AMD gene therapy study almost parenthetically because it is closed. It closed a couple of years ago, but the study results haven't been published. This treatment is called HMR59, which uses an intravitreal injection of an adeno-associated virus to deliver the code for soluble CD59. Soluble CD59 inhibits one of the final steps in one part of the complement system. However, as I said, to date, there have been no formal reports of the results of this trial. Finally, I mentioned that I'd touch on other approaches and some of the work conducted by my group. And one such approach is called optogenetics, which might be suitable for patients with advanced sight loss from dry age-related macular degeneration. So, as Mark touched on earlier on, we know that the mechanism of sight loss in retinal degeneration, such as macular degeneration, is through the loss of the light-detecting cells of the retina, the rods and the cones. We also know that the cells which normally convey information from the rods and cones to the parts of the brain involved in vision are relatively well preserved. The problem is that they're not normally light sensitive. And so optogenetics is an approach to make these relay cells light sensitive via gene therapy. And this gene therapy aims to introduce into these relay cells a light sensitive protein. So our group has been investigating a few different proteins to restore vision in retinal degeneration. These proteins can be from microbes, and there are two that we're using. One is called breaches, the other is called carmine. We can also use human light-sensitive proteins to confer light sensitivity to these relay cells. So we're using one such protein, which is normally found in the cones cells of the retina, and this is the long wavelength cone opsin. And this protein we're aiming to express in the retinal ganglion cells or the relay cells to make them light sensitive. On the right here, I've got some images of treated retinas as well as responses from a retinal ganglion cell following optogenetic gene therapy. So this is a fundus following treatment, and the gene therapy results in a fluorescent appearance if it's successfully produced the protein in the target cells. So you can see here that this retina is strongly fluorescing. We've got some histological slides here or images from a microscope. Again, treated cells are glowing green to prove that we've got protein expression. In terms of function, we have here in the bottom left of the insert some responses from a treated retinal ganglion cell in response to light. So normally there'd be no electrical response. There'd be a flat line following light stimulation in a retinal ganglion cell of this type. But here we can see multiple spikes indicating that this retinal ganglion cell has been rendered sensitive to light following optogenetic gene therapy. So in summary, we've seen that retinal gene therapy results in sustained protein production in the eye. There's evidence to suggest that anti-vascular endothelial growth factor gene therapy may reduce treatment burdens and this approach is currently in phase 3 pivotal trials. The efficacy of gene therapy in atrophic AMD has not yet been reported, though it appears to be safe, and it's currently in phase 2 trials. And finally, there are emerging approaches, I should say, such as optogenetics, which may in the future be used to restore vision in those with advanced sight loss from atrophic macular degeneration. So that's it from me. Thanks everybody for attending, and thanks to the team at Safe Sight Institute for arranging this webinar.
All right, were there any more questions? Let's have a look at the question board. Well, I think that's it for presentations. Does anyone have any other things they'd like to ask Matt or myself? All right, so Veena Murthy is asking, I'm interested to know how optogenetics might apply for childhood blindness.
It depends a little bit on what's caused the childhood blindness. Primarily, optogenetics is being investigated as a treatment for people who have disorders of the outer retina, and that's a lot of people who have retinal degeneration. I recently heard a talk from somebody in New York who's developing an optogenetic approach actually to introduce proteins into cells in the lateral genicular nucleus, which is part of the relay system between the eye and the parts of the brain involved in vision. This will require a neurosurgical device to be implanted to stimulate nerve cells in the visual cortex with light. That might be applicable for example, patients who have loss of retinal ganglion cells or other forms of childhood blindness.
I think the thing about optogenetics is very attractive, but it's basically a way to short circuit the loss of the photoreceptors by getting in further down the relay pathway, as Matt said, and making the cells in the retina, which usually relay the signal, make them actually detect the light signals. But the trouble is that we know that a lot of processing goes on in the retina. As much of the retina is horizontally organized as it is vertically organized. And so presumably that's modulating the way the retina is picking up and transmitting these signals. So we really don't know yet what people who have successful optogenetic intervention, what their vision will be like. That is the great unknown. No one has yet got to the point where they're using this in humans and we're seeing the clinical results yet. So this is probably the nearest thing that's going to happen to restore vision, and it will be very likely to be better than the bionic eye, which really can only get people to the top letter on the chart at the very best. So it's probably going to be better than that, but how much better than that, we don't know.
Yeah, there's been one, so no reports from any of the early phase trials, with the exception of a report by Sahel and colleagues of one patient treated. So because of COVID, this kind of put the kibosh on much of the clinical trial, I understand, but they reported the restoration of some ability to sense light and to detect objects in a patient who had profound vision loss with optogenetic gene therapy. They used some stimulus goggles because the protein that they used was not particularly sensitive to light. But as you say, Mark, it remains to be seen whether or not such stimulus goggles may be required or not if we have more sensitive proteins. Taking the analogy of the bionic ear, they thought at first that they would need, a multitude of electrodes, and they were pleasantly surprised when they inserted the early devices that only had sort of several electrodes in terms of function. So we may actually be able to get on a lot better with limited information.
So I have another question now. Are eye drops being investigated as an alternative to any injection treatments? Yes, certainly there is one trial that we're doing at the moment where we're using eye drops to treat diabetic macular edema. The trouble with eye drops is you can't get drugs in any great concentration to the back of the eye as an eye drop. They've got to be extremely permeable and relatively small. You certainly couldn't get a gene therapy, for example, as an eye drop. It just wouldn't penetrate through to the back of the eye. But there are some eye drops which are being tested now for diabetic macular edema. I'm a little bit skeptical myself. They often work in animal models, but no one has translated that yet into a human. But once again, you can do as much as you like in the laboratory and in animal models. The crunch is when you get to the phase 2 and the phase 3 clinical trials, which is what we're presenting today, because that's, is most immediate interest to patients. These are the things that you're going to see, and in the sort of the next 3 to 5 years. And it's possible that they will have something for diabetic macular edema, and then I guess they may try to use that in neovascular macular degeneration as well. But there are not a lot of studies, just one major study on eye drops at the moment. Do you have any questions, Matt?
About eye drops?
Anything about
I guess the other thing is that, back in the day, it used to be called compliance, but when I was in medical school, they overhauled that term and called it concordance. So one of the problems that is perceived as being an issue with eye drops is sort of people continuing to take them, especially when other kind of events in life take precedence.
Yeah, at least you do an injection, it's in there. All right. Well, I think that's about it. Thanks everyone for your attention. As I said, I think in the chats there you can see the link to the Macular News, which we publish online, and we release that every 6 months in autumn and spring, with the latest developments from the Macular Research Group, and I think Matt can sometimes put something in that as well. So thanks for your attention. We'll be talking again. Oh, there might be another question here. Yes, there is. Is there a study using nano robots to deliver the treatment? AAV.
Yeah. So nanoparticles. It's something that I guess there's a local interest in at the University of Sydney. So not yet, but nanotherapeutics is a big area. There may be certain advantages to it. Mark, you're working on.
Yeah, we're doing that. We're currently using nanolipids, tiny lipids, to make payloads to deliver things like gene therapies, mRNAs, and those sorts of things to the retina. Yes, that's something that we have a very active interest in, and we're trying to find particular formulations which target special cells in the retina where the genetic defects are. And there's a lot that you could potentially do with mRNAs influencing various networks in the retina. And someone asked about MacTel before. So there's a gene called, there's an enzyme called phosphoglycerate dehydrogenase, which is the first enzyme in the whole chain of enzymes which makes serine. So we think that in delivering PHDGH mRNA to the retina could be a treatment for MacTel. So we are currently developing nanolipids so that we can deliver mRNA and other gene therapies to the retina.
Yeah, the other thing about it, I guess, Mark, is that you can come up with a multitude of different nanoparticles which may target preferentially different parts of the retina, as you said. So that could be a great advantage, whilst potentially simultaneously minimizing the effects of intraocular inflammation.